Our next speaker is Dr. Lili Chan. She's an associate professor, Division of Nephrology at the Mount Sinai Hospital. And she's also a member of NIH-funded, or conducts NIH-funded research, and she has wide interest into the application of AI, especially also into natural language processing, among others. And she will talk about bridging AI, social determinants of health, and kidney outcomes. Really, thank you, Lili.
Thank you. So thank you to the organizers for inviting me to give this talk. When I spoke to Len, like, what do you want me to talk about in this session? He's like, well, everyone's talking about their institutions and everything. So I was like, okay, let me put in a slide about Mount Sinai. In case you don't know where Mount Sinai is, it's actually a beautiful picture. It's very misleading. We are located right off of Central Park in New York City. We are made up of multiple different hospital systems. I am located at the main Mount Sinai Hospital, which is this beautiful black building here. We also have this one, this is the main hospital. And what we are also interestingly located is that here you have the Central Park, Fifth Avenue, very, very wealthy people with a beautiful view of Central Park. And then this building over here is actually the New York City housing, which is specifically for people with lower income. So we have a very diverse population, which does allow us to then collect data from our health systems from very, very different types of people. We are overall 3,000 beds. We have 2,000 residents and clinical fellows, and we have across the health system really been using the Epic EHR, which is the really big one, since 2010. And the important thing is that we also have invested in the infrastructure to collect all of this patient data in the Mount Sinai data warehouse, which does allow us to do a lot of research, including AI research, and also the Minerva supercomputer, which is just a lot of GPUs that allow us to computationally and hardware handle all of the models that we want to do. So I'm going to start off with highlighting a couple of the projects from my colleagues. In prep for putting this talk together, I was like, well, how many models are actually getting deployed out there in our health system? And the answer is 65. And I was really impressed with how many the number of models that we're getting out there. I believe most of them are radiology oriented. A few of them in nephrology are in the pipeline, and so these two are the ones that I'm going to highlight because this is a nephrology conference. So this is actually led by Ira Hoffer. He's an anesthesiologist with a specific interest in developing and looking at models for post-operative AKI. And he used features that he collected at the end of surgery, including drugs, blood loss, vital signs, and then he did not a composite outcome, but different outcomes of mortality, AKI, reintubation, and then a combined outcome. So he had 59,000 surgical procedures, and here on the bottom you can see the design of his models, where he has any of the outcomes, and then he had the multitask learning on the right side, where he had one model for each of the different outcomes. And what he did show is that all of the models that he developed worked really well. The AUCs were ranging from 0.67 to 0.906, and this consistently outperformed the standard structured model, which physicians use, called the ASA physical status score. And that model is that kind of straight black line over there. And moving on to my other colleague, Ankit Sagucha, he's actually a nephrology critical care. He's been really doing a lot of interesting work in the critical care field. And so this was work where he was at, I believe, Virginia, before he joined us at Mount Sinai. And what he did do is he developed a model that was looking at clinical decision support that identifies or triggers like, hey, this patient's going to have AKI. Here are some things, especially nephrotoxins, that should be avoided. And so he looked at it and he broke it down to the 5 different eras of when they were in the deployment and implementation of this model. And this is an example of what providers were seeing on the electronic health record side. So it says, okay, well, based off of the creatinine, here's your stage of AKI, additional some footnotes. Here are some medications that you may want to consider stopping or changing. And here is what they found. So across here, you have the different stages of the clinical decision support implementation. And again, his primary outcome was looking at discontinuation of nephrotoxins after AKI. So that's this line over here in the black. So 1,000 patients, 1,300,000 patients met their inclusion criteria of 500, which ultimately developed AKI. And on their adjusted analysis, they did find that there was an improvement, an increase in discontinuation of nephrotoxins as the tiered implementation kind of went on. So this has already is undergoing a silent deployment currently at Mount Sinai. He's hoping to have it become active and be first deployed to the intensivist at Mount Sinai and then across all providers if there is positive feedback. And this is Kidney Intellects. I'm hoping maybe some of you guys know this. Steve Koka and Girish Narkarni are co-founders of this company, and what they did is they developed an AI random forest algorithm using data from Mount Sinai. Initial validation was in UPenn Biobank, but now has actually been tested across multiple different cohorts. And what they did was they focused on patients with diabetic kidney disease and tried to improve upon the prediction of who would progress, because we know that patients with diabetic kidney disease, some never progress, some progress rapidly, and some just kind of some actually get better, which was also very surprising. In 2019, they did have FDA breakthrough device designation, and they've been working on a lot of real-world evidence. So this is how the Intellects actually includes information from biomarkers, clinical data, and then it goes into the validated algorithm. And the goal for them really is they want clear, actionable results that can help the clinicians and patients. And so patients, based off of these things, would get into either low, moderate, or high, and then a report is generated on potential actions that providers and patients can take. So this was their real-world interim analysis done at Mount Sinai. They had over 2,000 patients across 25 locations and 80 providers. This included primary care, internal medicine, and also the nephrologist. Anyone with type 2 diabetes was included, and this was from 2020 to 2022. And here are some of the outcomes they looked at in this study. And one was about new referrals to specialties. And what really is interesting to see is that there was an increase in high, people who were predicted to be high, which is the top, intermediate, and low, and you can see that more referrals were made in the high, which is what you want. You want your people who are high risk to be seeing nephrology, and then if you're low risk, then maybe they can continue to follow with the primary care provider for now, and then hold off on that referral. They also looked at the use of medications for diabetes like SGLT2 and GLP-1s, which we know now are disease-modifying. And you can see that before implementation, because after implementation, there was an increase in use, and this was part of the kind of treatment guidelines that are distributed to the patients and the providers. So we're going to switch talk a little bit to the social determinants portion, which was part of the title. And this is a kind of my research interest. So what really are social determinants and what are social risk factors? So social determinants, I think, is the overall larger level of things, where people are born, where people work, and how they age. And they're really neighborhood and larger things. And while we often talk about them interchangeably, they're not the same thing, because social risk factors are really things that affect people on an individual level. So things like housing instability and financial insecurity are really on an individual level rather than a neighborhood level. This work is really led by one of our medical students. She's now going to be a third year, and one of our coordinators. And I also want to give a shout out to Roxanne and her team, who's managed all of the recruitment from the RRI sites. So we believe that health-related social risk factors really can cascade down to multiple different outcomes. The first study we looked at was quality of life, and then the second one was hospitalization, and some new results for that I'm going to be sharing here. So again, we recruited patients, 324 patients from 5 dialysis units, one that is from Mount Sinai Hospital and 4 from the RRI units. Anyone who was over the 18 could speak English or Spanish and had been on dialysis for over 30 days. And we screen patients using 2 different surveys. One is the KDQOL, and this is for quality of life. It's made up of 5 different components, each of which are scored independently. There is no composite score. The second is the CMS, which is Center for Medicare and Medicaid, has developed a health-related social needs screening tool. And what it screens for is actually about I want to say 19 different outcomes, but 5 of which are core: food insecurity, housing instability, transportation problems, utility health needs, and interpersonal safety. For the KDQL, lower scores indicates a larger impact of disease. Some patient demographics. We have a large proportion of Hispanic identifying and Black identifying individuals in New York City, and especially across our dialysis units. A fairly even split, a little bit more male gender in our study. So this is the distribution of health-related social risk within our 5 dialysis units. And what I wanted to point out is that more than 50% of our patients reported having at least one social risk factor, the most common being food insecurity and housing instability. And when we saw this, we were quite startled with, like, wow, that's a really, really big number, and we have to figure out how to do something about this. I would say that for further analysis, because we had such a small number of people with interpersonal safety, we decided to omit that as a covariate because we didn't want to generate results which may not be actually applicable because it was only 1% of patients. Here is a distribution of quality of life subscores for all of our patients, and I would say that these numbers are quite a bit lower than what is reported in patients who are not on dialysis. Again, lower scores indicate a larger impact on disease. And so here is our multivariate linear regression. And what I really wanted to highlight is all of those in bold were statistically significant. So many of the different social risk factors were significantly associated with the different quality of life scales, with the largest effect size really being on the burden of kidney disease score. And this is most recent results. Is that we have also looked at non-elective hospital admissions within 12 months of when the patient was enrolled in the study. And you can see that those who had a social risk factor were more likely to be hospitalized within the next 12 months by housing instability, transportation needs, and food insecurity. And in our regression model, logistic regression model, we did also find a significant association for having more than one SR associated with hospitalizations. So where does the AI come into for this work? Is that we are trying to develop a way for us to identify these social risk factors from the electronic health records, because it's really hard to, I can tell you about 2 years of time for us to survey those 320 patients. And is any of that in the electronic health record? Because a lot of us are probably already talking about it with our patients. And so here is our pipeline. At step 1, we collected all of the notes from patients 6 months prior to enrollment and 6 months after enrollment, so around 1 year of when they were included into our study. We removed notes that were not likely to include information, so a lot of times within our electronic health record, it says the nurse's document, the patient arrived. That's really not informative, and so we dropped those. It accounted for about 20,000 notes, and that still left us 12,000 notes across 300 patients over 1 year. We then had a prompt, a large language model, that then asked to help us classify whether or not the social determinants are present, and then the last step was to answer it specifically for the screening tool. So here's an example of the notes. This is actually a shortened version. What's interesting is this is our template, so a lot of them are these little brackets with X's where X indicates that it is there. And you can imagine logistically how hard that is for us to parse out. But also highlighted in red over here and here is actually the documentation of some of the social risk factors. So the patient has reporting good social network of family, reports stable home life and living situation. So we tested 3 different large language models, Mistral, Llama 3.18 billion, and Gemma 2, which is the locally run Gemini version. And notable, we did not use ChatGPT because ChatGPT uses OpenAI servers, so we are not going to send our PHI full progress notes out into OpenAI for processing. So these models were all run locally within a personal computer. So these are things, if you want to do, and to do the research, I would definitely look into these. Here is the prompt that we used. You are a clinical reviewer. Given the note, classify whether social determinants are present. Only mark true if it is, and put it out into a JSON format We also asked it not to assume or infer from the language, and just simply say true or false. So of the three, Mistral actually performed the best. We were surprised. We thought Llama would be better, or even Gemini. And here is the output. I'm only going to show Mistral due to the time. And so what you can see is living situation. Remember, this is the results from that same note that we just looked at together, is that it's actually saying, yes, it's there, which is true, but the patient didn't actually have housing instability or living situation problems, but it did provide the context of the note that it's referring to. So I would say not quite right. And some of these other things, again, are not quite right, but it does at least identify that these things are present. So what's also interesting is that, sometimes when you do a lot of notes and you have these prompts, is that not all of them are going to result in an actual full response. And so of the 12,000 notes, about 74 of them we got a full response with, and the remaining 25% we had no response or in a partial response. And even then, some of the formatting was wrong. We also had manual review done of all of the notes. And so right now it's only one reviewer, so we do have to kind of do more, but it was a lot of notes to review, so thank you to my reviewers. And what you can see is that the identification by the Mistral here far outweighs the number that was identified by manual review. But for the manual review, the overlap between that is actually quite high. So if it is there by a manual reviewer, then it is very highly that the model will be able to pick it up. But whether or not we have to decide is whether or not we're missing it or the model is calling false positives. Results also depended on a little bit of what the outcome we were looking at or social risk that we were looking at was. And I'm going to skip that. So where are we going from here? We really need to fine-tune this. Right now, it's a zero-shot approach. We're going to have to pull examples and really fine-tune specifically for Mount Sinai. I'm also worried that a lot of the documentation isn't going to include those social risk factors. So it'll be really interesting to see how it compares to our surveys. And we do have a grant up for review actually next week. This is work with Len and his team to build models to identify the social risk factors because this information is good and collected at the Fresenius units. And then we also have a chat bot that we have piloted with some of our patients to help screen for and hopefully refer them for social risk factors. And so this work is collaborative and has a lot of people who contributed to it, and I will stop there. So thank you.